I want to hand over now to Jonathan Berry, who's the National Lead for Shared Decision Making in NHS England. Jonathan has spent his career working in both the NHS and the third sector, not-for-profit sector, NGOs, in the field of patient experience and involvement. He set up a variety of advocacy and support services for patients over the years, and he led the development of the National Skilled for Health resources on behalf of the Department of Health and Department for Education in England. And he draws upon his huge experience to ensure that shared decision making really takes into account issues such as health literacy and to address health inequality as well.
Thank you very much, Jim. Thank you very much for that introduction, and good afternoon, everybody. And it's an absolute pleasure to be here to talk to you today about shared decision making. And I guess actually the last slide that Jim showed about people's responses to the National GP survey really just demonstrate how important it is that we continue to really press ahead with this work, because those stats around, 40% of people not feeling they were actually as involved as they wanted to be in decision making about their healthcare and treatment, those stats have remained pretty much the same for about the last 10 years or so. So we've clearly got a lot more work to do. What I hope to do today is just give you a brief overview as to what shared decision making is, where it fits into the policy agenda, a little bit of an explanation as to why we at NHS England think it's important, and then just finish off by talking you through what we're doing to try and implement it within the health system in England. And I would argue that in a time of a pandemic, that shared decision making, and I'm probably speaking to the converted here, but I would argue that shared decision making is probably even more important at the moment than it's ever been, because in addition to all the usual decisions that people need to make about their health, their care and their treatment, they've got to make additional decisions about actually what they want to do in the context of a pandemic, in terms of actually in some cases just setting foot into a healthcare setting. And I think the point of this slide, not to dwell on it, but is really to be clear that actually shared decision making, often called other things, has actually been around for quite a long time. And in fact, if you go, I would argue, go right back to the 1960s and 70s with the establishment of organisations in England, such as community health councils. It's been called different things: patient experience, patient involvement, but in essence, that's what it's kind of been, really. It's been about ensuring that individuals are supported to make the decisions that are actually right for them, that they can understand their care, treatment and support options, and also what the risks, benefits and consequences of those options are. And that option always includes doing nothing or doing nothing new, and then make a decision about their preferred course of action. And the sharing, of course, comes from the understanding of the patient perspective, the patient preferences and values and circumstances, but also the clinician brings to the table a very important portion of this conversation, all about the evidence-based, good quality information that clinicians often know about the risks and the probabilities. That's the decision that that's the definition, I should say, that we in NHS England use when we're describing shared decision making, and it comes from our universal personalised care publication. We've also got a national collaborative with a whole range of different government and non-governmental agencies, which sort of brings people together, a network who are interested in shared decision making, to advance its profile. And that definition is led by an organisation called NICE, the National Institute for Clinical Excellence, and they've also defined it, and it's not too different a definition from our own universal personalised care one. And shared decision making is a significant component of what we're calling in England personalised care. If you wouldn't mind moving to the next slide, Jim. And there, I think that really just basically shows you that as far as we're concerned, shared decision making, which is at the bottom of that pyramid, is one of the personalised interventions that we would expect to see the whole population being a recipient of, because it's actually about our view that everybody should be able to have a shared decision-making conversation and then make a decision about what they do or don't want to do with regard to their health and well-being. I guess there's always a question, isn't there, that why? So what? Why is it important? Well, I think here are some of the reasons why we think it is important. I think, bearing in mind that this session today is all about patient experience, improving patient experience. I think the top thing there, which is it can create that new relationship between individuals and professionals, so much more based on partnership than the old-fashioned, rather patriarchal model of care, is absolutely crucial. Jim's already touched on the fact that people want to be more involved than they currently are in decisions about their health and their care. And also, I think this is a really important one as well, the third one, that often what you find is that both individuals and clinicians can often overestimate the benefits of treatments and underestimate the harms. So a good quality evidence-based, health literate shared decision-making conversation can actually iron some of that out and actually really expose what the real risks and the real benefits of treatments, as well as the harms of treatments, might actually be. In terms of us as a system, if you get good shared decision making and people make the right choice for them, their circumstances and their preferences, then you've actually got the potential to enhance the way that we allocate resources and actually reduce unwarranted clinical variation. And I think that's a really important driver for the system. And in England, and in fact actually in the UK, because this is a case that originated in Scotland and went to the UK Supreme Court a few years ago, a case called Montgomery versus Lanarkshire Health Board, the Supreme Court have now ruled it's a legal requirement to do shared decision making, and health professionals must now take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable variant and alternative treatment. And although they didn't use the word shared decision making in this case, because the case primarily focused on consent, the way they describe what health practitioners now need to do basically is how we would describe shared decision making. And finally, from a professional perspective, it's absolutely intrinsic in the codes of conduct for nurses, therapists and doctors. Obviously, it wouldn't be right at a meeting like this not to mention there are some significant challenges to embedding shared decision making. Quite a lot of the pushback we get comes from people working in the system. It's about it takes too much time, people don't want it, you can't measure it, and we think we have a counter for all of those arguments. But what we cannot ignore as well is that if you're having the kind of conversations I've described, where you're talking about evidence, values, preferences, risks and benefits, that actually that requires quite a high level of health literacy and quite a high level of health literacy awareness among practitioners. And we do know from the research done a few years back now by the Institute of Health Equity and Public Health England, that between 43 and 61% of the English working age population routinely don't understand the health information they're given. Qualify that by saying that doesn't mean they don't understand everything all of the time, but it often means that they may miss the salient point. If you miss the salient point in a shared decision-making conversation, there's every possibility that the decision that you come to may actually not be aligned to your preferences and your values, which in due course could lead to decision regret and actually have quite profound impacts upon your life, because you could actually make decisions to have surgical interventions that then mean some of the things that are really important to you, you're no longer able to do. And of course, we're also very conscious, as we try to encourage shared decision-making conversations across the system, that there's an actual strong link between lower levels of health literacy and health inequalities. So what we really don't want to see is that we have shared decision-making conversations between clinicians and people who already have relatively high levels of health literacy and leave behind those people whose levels of health literacy aren't quite so high. So we are aware that there is this health literacy challenge, and that's why we often talk about having health literate shared decision making conversations. So I suppose that's a seamless segue into talking about changing the conversation. I guess this probably diagrammatically explains those definitions from earlier. And I think in its simplest form, this is what shared decision making actually is. Doctors share information, patients consider options, and together they make a decision. And it really is that togetherness, that jointness, I think, is one of the key underpinnings of shared decision making. In the conversation, in that sort of consultation between clinicians and patients, this is really, I think, what is being shared. That's not to say that every one of those situations, every conversation, you share all of those things. But I would argue that for a good shared decision-making conversation to take place, you absolutely do need to have at least some of those every time. And I would argue that sharing risks and benefits, from a clinician's perspective, is absolutely key. But also, from the patient perspective, your attitude to risk is key, but also so are your personal and social circumstances, because they actually may very much impact on the decisions and the choices you make around options around care, treatment, and or self-management support. And the other thing I think I really want to emphasize is that this is not necessarily a one-off, well, it shouldn't be a one-off conversation quite often. Quite often you have to go back to the conversation, have several discussions before you can actually share in the decision. So it's not always a linear process. But I would argue if you have all of those components, or some of those components, depending on circumstances, in a shared decision-making conversation, you're likely to have an optimal decision from the patient's perspective. I won't dwell on this because I think a lot of what is in this slide is repetition. But what I would say is that number 5 is a really interesting one, because what we've tended to find with shared decision-making is that when you have informed patients, they often tend to want less invasive treatment, and that goes across a whole range of different disease areas and specialties. A good example often is palliative chemotherapy. If you have patients who really are informed about all the risks and benefits, side effects, alternatives, and variants around palliative chemotherapy, you often find they opt for other options, because they actually find that those other options mean that their quality of life might be more enhanced, even though they may be doing a bit of a trade-off in terms of length of life. And what I would also say is probably worth reflecting on number 4 as well, which is actually there's often a dissonance if we don't have a really good healthy shared decision-making conversation between what clinicians think patients want and what patients themselves actually do want. So that's why we should share decisions, all of those reasons. Again, I won't dwell on this, but what I would say is I think that all the major codes of conduct have now got it absolutely at the centre of good professional practice. And indeed, in England recently, our General Medical Council, which is the organisation that governs doctors' conduct, have actually really been helpful and referenced shared decision making very heavily in their guidance on patient consent. And I suspect none of us would disagree with all of those bullet points, which is working in partnership, responding to concerns and preferences, giving people information they want or need in a way they can understand, and respecting people's rights to reach a decision with you about their treatment and care. But I still think, although many people now say that is absolutely the right way to practice, I still think we're a long way in reality, as the statistics that Jim showed at the beginning, from that being an actual reality for everybody's experience when they are in front of a clinician in the healthcare system. And I won't dwell on the Montgomery case because we've talked about that. But what I would say is that it did also, in the words of the Supreme Court, it did actually give appropriate recognition to patients as decision makers. And I think that's the first time that that sort of legal recognition of patients as decision makers in England, and of course in the UK, because it applies to the UK, has actually been made. People often ask me, when is shared decision making appropriate? And to be honest with you, I think it's appropriate almost all of the time. So perhaps if I were to be knocked over by a bus and rendered unconscious in the street, perhaps I wouldn't want the paramedics or whoever is attending me to wait for me to become conscious before asking me what my preferences and values and circumstances are. I think I'd probably rather they got on with saving my life. But in most other circumstances, in primary, secondary or tertiary care, where there's more than one reasonable course of action and the decision involves trade-offs, like the one I was talking about earlier around quality and length of life, I think shared decision making is absolutely appropriate, and particularly when there's uncertainty or unclear evidence, or where different options have different inherent benefits or different inherent risks. This is where patient values, heart of shared decision making, are absolutely vital, I would suggest, in optimizing the decision from the patient's perspective. Then what are we doing in England, in the NHS and other sectors to try and implement shared decision making? These next few slides will take you through what we think the 4 key components of shared decision making are, and what we're trying to do in each of them. Some work was done a number of years ago in a number of different healthcare settings across England, and that was really aiming to look at what are the absolute foundations, ingredients for successful shared decision making. And it was called the MAGIC program, and it stood for making good decisions in collaboration. And what it basically said was, if you have supportive systems and processes, trained teams, prepared patients, and commissioners supporting continuous improvement in shared decision making, that is the optimal way forward. Very uncannily the same as the ingredients that Jim spoke about in terms of successfully embedding health literacy into practice earlier. So if you get all those 4 right, then basically what you're going to have is shared decision making as usual in practice. I'm going to take you now through each one of those very briefly, and just tell you what we're trying to do about that within NHS England. What we're doing is we're working with our commissioners in our clinical commissioning groups via our regional teams, our regional personalised care teams, to support commissioners to think about whenever they're realigning or redesigning clinical pathways, whenever they're looking at local delivery plans and logic models, that they always bear in mind that shared decision making needs to be in there. So, and a really good example here, I mean, I think is that, with the importance of self-care, social prescribing, if you have a conversation with a clinician and the decision is made that actually what you'd like to do is maybe join an exercise club because you're a little bit isolated and lonely, and you've also got really difficult, challenging, problematic knee pain, and what you basically need to have is a pathway that enables a clinician to refer you to a community group that does gentle social walking. If you haven't got those pathways in place, then it's really, really hard for the outcome of a shared decision-making conversation to actually be actioned in reality. So that's what we mean by that. And what we also are saying to our commissioners is, think about how you can align commissioning incentives and measures to actually support shared decision making. And we have 1 or 2 examples of that beginning to emerge across the country at the moment. Things were moving along quite nicely, and of course a lot of this got paused unfortunately by the pandemic. The next one please, Jim. In fact, Jim probably is a better person in many ways to talk about this than me, because we do recognise that training clinical teams is absolutely vital for shared decision making. And we've just set up a personalised care institute to provide training across the entire spectrum of personalised care. And I'm really pleased to tell you that just the other day, that institute launched its first introductory e-learning module on shared decision making. So we've already started looking at how we can actually get that training rolled out across the system. So the next one please, Jim. And I think this is really vital as well. I think this has been the area I feel most passionately about, which is that we've often talked about the need for cultural change with regard to clinicians talking to patients, but we've often forgotten is that we've historically had quite a paternalistic model of care delivery and service delivery. And what we actually also need to do is start to think about how we can work with people who are going to use services, prepare them to actually start to have the kind of conversations with clinicians that begin to share in decisions in a much more equal kind of way. So what we've been doing is we've been actually thinking about how we can issue guidance to the system to actually get them to think about how they can encourage people to ask questions, how they can encourage their clinicians to take more account of health literacy, and also at the same time we're looking to launch quite shortly a public-facing infographic to try to explain to patients why it's absolutely vital, especially in the context of the current pandemic, why it's absolutely vital, whether it's face-to-face or in a virtual consultation, that they really do believe that they can ask questions and they really do take advantage of the opportunity to do so. It's going to take a while for that to percolate through, but we're really, really passionate about that. And then finally, Jim, the fourth element is, and that's basically stuff that we're trying to do through our leadership of the system to try and get the local system leaders to understand that you actually do need to have leadership for this work. And I would argue for all elements of personalization and all elements of patient experience. If you don't have good strategic leadership and clinical leadership and some kind of system in place to try and measure how well you're doing at this, that ultimately what you may be doomed to are a series of excellent local initiatives, but initiatives that never gain the momentum or the sustainability that we want if we're going to really make that cultural change that we're also passionate about making. We have developed a number of resources to support our work and kind of looking at a patient's experience of shared decision making, looking at an organisation in Sussex who've actually embedded shared decision making very successfully into their musculoskeletal work. We've also developed a checklist for systems to actually look at how well they're doing in terms of implementing shared decision making. And we've also we also refer people to the National Health Literacy Toolkit that Health Education England hold on behalf of the system. And what we were doing until the pandemic unfortunately curtailed this, we were actually beginning to mentor sites who wanted to do more on shared decision making with sites who were further along that journey, so they could learn from each other. But as I say, that all got a bit curtailed by the pandemic, but we are hoping to come back to that when circumstances allow. So that's been a very quick gallop, an overview of shared decision making. I hope people have found it interesting and useful. If there's any further information that people want, at the very bottom on the right of that slide, you'll see the contact details of our generic email address, which is england.shareddecisionmaking@nhs.net. So, as I say, hope it was helpful. Thank you very much for asking me to be here with you today.
Thank you, Jonathan. That was an excellent overview, and